Well, I hope you're all beginning to get the message by now. We've heard from the surgeon, we've heard from the radiation oncologist, and now we hear from the most important person, which is the patient. And we are lucky to have a very brave lady, Mrs. Marcelle Bernstein. She's a journalist and novelist, and she herself says that she opted for target therapy 5 years ago. She says one of the best decisions she'd made. She wrote the article in the Daily Telegraph about the treatment, and I think we've seen that. And she's been a patient expert on 5 NICE committees and member of the steering committee for Target B in younger women. And so this is a lady who not only knows it from the inside out, but also from the outside in. Mrs. Bernstein.
Oh, can I have my rainbow back? I haven't got any pictures, so I'm borrowing Jay's rainbow, which is how I feel about Target, I have to say. While he's doing that, I just want to say how lovely it is to see you all here today. It is a big rainbow, big as you can go.
It'll come.
Well, there's the thank you. Oh God, I hate technology with a passion. Don't worry.
It'll come.
He's coming. But it is lovely to see you today. We have had a real time, brilliant, getting Target to this point, and it means so much to listen to the level of intelligence, of expertise, and from all of you, of enthusiasm here. It's absolutely wonderful. I'm going to read bits of that out to you, but not very much. Right. So it's wonderful. Okay. Now, can I say that I'm not in my best state today, and I may probably ramble and go off at tangents, so I'll apologise. I always do that anyway, so it probably won't make very much difference. Now, I'm not a medic in any sense of the word, as Margaret made clear to you, I think. And I have been the patient expert, and the 3 wonderful professors who are my heroes, I have to tell you, they are my absolute heroes, the Target professors, tell me that I am their poster girl for Target. In which case, I really felt I ought to have turned up in a low-cut dress and a push-up bra. But I couldn't bring myself to it, it was too cold. So I'll tell you a little bit about what happened to me, because it's a fairly typical story, except that mine was 5 years ago, and more than 5 years ago now. And at that point, we had private medical insurance, which was just as well, because we've only just got this onto the NHS, and it is slightly limited. We're not out there for everybody. You've got to find Target. But 5 years ago, it was more or less accepted by, you'll get more of this, by the health insurance companies and by the hospitals. So what happened was that I had a mammogram, and I expected the usual, as Michael was saying, the usual casual thing back, and I wasn't even bothered about it. I'd had lots. I was, how old was I? 70. And I was shocked when I got back one of those letters saying, will you come back again? And I thought, well, it can't be anything. But of course, it turned out that it was something. It was something. When I heard that I'd been called back again, I knew I was in trouble. At no point, incidentally, and I thought this was interesting, did I see my GP. Or did it even cross my mind to go to my GP, which looking back was ridiculous, because she's very nice, she's a lovely French woman, she would have been great. But somehow, as somebody else said, this thing speeds up, doesn't it? Oh, it was Paula, I think, who said that. It speeds up. You've got this 30-day thing. They push you along. And I'm not someone who likes to be pushed, but you're worried, you're anxious, and you don't know the ropes. Now I know the ropes. Believe me, it's a very different picture. So I had a bad experience. I'm not going to give you the names of hospitals because I'm about to be extremely rude about him. I saw a locum breast cancer surgeon, which was awful. He sat at his desk, and he had his back to, I'm there, right? And he had his back like that, and he was writing like that, and quite a lot of what he said was in, you hear it anyway, right? So that was my first discussion with a breast cancer surgeon, and he told me that I had a tiny invasive, very aggressive breast cancer, and what I should have was a lumpectomy. Okay, fine. And then he talked to me for a little bit. He didn't say very much, and it wasn't very informative. And he said, a lumpectomy. And then at some point during this, I said that I was an Ashkenazi Jew. Whereupon he suggested I have a mastectomy. Just like that. No genetic testing, no telling me there was, I'm not making this up. Eric and I recorded this. He didn't even tell me there was genetic testing. I found out myself later. And then he said, and of course, it could spread to both breasts. At some point in the future, this might happen. And at this point, I'm thinking, well, I love my breasts, but I love life more. So, okay. And he said, so we're up to a double mastectomy, and I've been there in his office 8 minutes. And Eric and I were both in shock. I took my husband with me. Always take someone with you to a meeting like this. Never go alone. If I've learned one thing, never go alone. And as we then sort of felt like, and the breast cancer nurse who was sitting in with us was very sweet, and she was sort of doing that to me, like, let's get out of the room. Even she was doing that. And as I went, this guy shouted after me, and I have it on tape, can I book you in for the big one? Nice. I know. A friend of mine who did have a mastectomy told me that it was fine and it was okay and she had to have it and it couldn't be helped. But the worst moment came the night afterwards when they fed her. She was in the hospital, obviously. They fed her the hospital, and the dessert was a round pink trifle with a raspberry in the middle. I don't know why that image is so horribly vivid, but it is, isn't it? I also knew I was in trouble because 20 years before, my mother, I'm not trying to throw everyone, my mother had died from breast cancer, and she had died horribly and sadly and slowly, and she had not told anybody about it until she fell down one day and couldn't get up. She knew she had something because her nipple had inverted, but she never told us this till afterwards. She used to get up every morning like an old Jewish lady in a shtetl and say to it very firmly, no, no. And then she got on with her life, but of course she didn't get on with her life. So I knew how awful it could be. So I knew then that the conversation I'd had with my mother, which never really took place, needed to change. Now there are brave people around, many of them, most of them women, after all. Kirsty Lang was a perfect example. Celebrities, television personalities, actresses, people who come out, writers, people who come out and talk about their breast cancer. And we also marvellous the conversation is changing. My mother would never have been like this today. The conversation is changing. But nothing has changed the conversation more than Target, as far as I'm concerned, because it's changed the whole landscape of what there is on offer. And I know now they keep telling us, oh, there's marvellous new drugs are coming along. I read about one only the other week that's going to be able to treat breast cancer. But we all know that powerful drugs have powerful side effects. And the marvellous thing about Target, when you have it, is that it is so gentle. Well, when you look at the pictures of it and you see the thing going in, it doesn't look gentle. But it is. It's kind to patients. It really is. So let me just tell you very quickly what happened to me. Because of my mother, I had promised myself that if ever I got breast cancer, I would seek the best advice in the country. So I emailed Mike Baum. At this point, he was semi-retired, to my horror and fury. And I said to him, look, I realise this, but I'd always promised myself I should come to you. Who would you recommend? And 2 hours later, I got a call. Now, Jay, you're going to have to forgive me for this, because I didn't expect a call fast. I didn't expect it within 2 hours. And so help me, I thought it was an Indian call centre and they were going to offer me double calls. Jay does sound him, you have to admit. And he said, Miss Bernstein or Mrs. Clark, I forget what you told me. And I thought, oh my God, it's one of them. Jay, sorry. Thank God I didn't put the phone down. And then it all happened very fast. I went to see him at the Princess Grace. I sat next to a very savvy American woman who said to me, I was supposed to be going home. I've been working in London for 2 years. I was supposed to be going home. I got diagnosed. I came to see Professor Vaidya, and I'm staying until I'm finished. She actually put off going back to New York to be treated. I don't know what bigger, plaudits you can have. I very quickly saw Jeff. I was suitable. We arranged it. It started to go ahead. It would have been it was quick, but it would have been even quicker if I hadn't managed to do it during the summer holidays. And I don't know how well you know Jeff, but he's a great one for his holidays. And I can't blame him for wanting to go to Switzerland, wherever it was. He did come back and he did me. Right? I was back at work very quickly. There were no complications at all. I didn't have any you wouldn't know I'd had breast surgery. I have to look for the scar. That's Jay. He's wonderful. There was no soreness. There were no problems. There was nothing. I was checked. I was fine. And it's not just me. During the work I've done on the NICE committee, I've talked to a lot of women about what happened to them afterwards. And I just want to read you a couple of them. This is a woman of 78. The treatment is brilliant, actually brilliant. I'm very fair-skinned and red-haired. I would have burned more than others with standard radiation. But with Target, I had no side effects of any kind. Now, this is a very impressive academic, a professor, a woman, obviously. 2 days after I left hospital, the roofers made a mess on the front step during a repair. I went out there with a Stanley knife, and on all fours, on a baking hot day, I scraped hardened asphalt for 2 hours. That's a measure of how I felt. There was nothing I couldn't do. 2 days after Target, right? What more do you want? I think that's marvellous. The one that I think is possibly my favourite is from a lady in North London, and I think you'll see why. I went into hospital at 9 a.m, was back on the ward at 2 p.m, and at 4 o'clock I went home and cooked salmon for dinner. Now, I think we can safely say that was Golders Green, don't you think? So it's not just me, it's other women as well who find how marvellous it is. I then, having had the surgery, having got better so quickly, I did a piece for the Daily Telegraph, which you saw, which was the hardest piece I've ever done. I don't write medical stuff, and it's very, very difficult. And I kept going back. I drove them all mad, saying, is this right? Have I got this right? Do I understand this? The hardest 600 quid I ever earned, I tell you. But we did it. And then I was asked to sit on the NICE committee, which was an experience a bit like taking part in the Trojan Wars, which is very big, it's very amorphous, you don't know where it is, you don't know who you're fighting, you don't know what's happening, and most people wear skirts. It was so difficult. We had meeting after meeting, went on for 5 years, and we thought we were doing well and that NICE were listening to us. I hope nobody's here from NICE. And we hope NICE were listening to us, and then something else came back, and some other query. Queries like, the one that really got me was, do we have to use a German machine? Now, what kind of thing is that? In a country where, I don't know how much fabulous German machinery there is in our hospitals, but I bet there is one hell of a lot. But that was an intelligent, NICE committee member, but obviously not. The other thing about NICE that I think was really frightening is how long it's held it up for people in this country when you can go to so many other places. Paula and Jill both went to Italy, and I remember Paula saying that she didn't mind going to Italy. It was cheaper than having it done at somewhere like the Princess Grace. She didn't mind going to Italy, but she really was bitter about the food. She said everything in the hospital food was white, which I thought she'd expected decent pasta at least, and she didn't get it. Perhaps I thought suitable for patients. I don't know what the argument is for that. So I'm over it. I am on the steering, as Margaret said, I'm on the steering committee for breast cancer treatment with Target for younger women, which is incredibly important, and we must get that through. But again, it will take time. So what I'm asking is for all of you is to go out there and spread the word. We need people to know. We need people to go to their breast surgeon and be able to say to them, well, if I'm suitable, I want Target. I want the quickest and the fastest. You've heard how you don't have to go back to hospital every time, how it preserves your organs much better, how the cosmetic outcome is brilliant. There's everything going for it. And you do get checked along the way. Professor Vaidya sees me regularly, and he says to me, there's nothing there and there's nothing to worry about. Target has worked. He says to me, I'm treating a ghost. And I believe him. Thank you.
I can't tell you how brave that talk was. And I now would like, please, all the speakers to come onto the platform. And also we welcome Professor Geoffrey Tobias, one of my very old colleagues, worked with him for many years, who was one of the very early people doing TARGIT, and Professor Michael Douek, also very much involved with this TARGIT program at the beginning, and
Christobel Saunders.
Professor Saunders, and Professor Christobel Saunders, who is a professor of surgery in Perth in Australia, was very early on in TARGIT also. And if you please all sit down. Now, I'm sure you've all got your questions. I know there are a lot of you that would want to say, me too. But I think it was absolutely excellent the way we've had the scientific aspects, the way the whole thing grew, the way it's gone out into the whole world, and also the patient's point of view. Now, Katie has a question already. Why don't you go next? You go
So we've got a question on the Latin Lounge Facebook group. TARGIT treatment, you say, saves the NHS money, time, staff. Why don't I sit at the end? This treatment, you say, saves the patient time, travel, burns to the skin, and most of all, mental anguish and emotional turmoil. My question is, if NICE will partially approve TARGIT IORT, why is the NHS not making this treatment available to qualifying patients? It says this is both cruel and so not necessary. Get this treatment out there. We deserve to be given the choice.
Who is going to address the elephant in the room?
Well, I'll start if you like.
Thanks, Geoffrey.
I'm happy to start if you like. Of course, the question is the most important one facing us in many respects this afternoon from the point of view of implementation of the TARGIT treatment. We had, as you heard, confidently expected that it would be possible to recommend this treatment far earlier than has been the case. And one of the reasons that I was very keen to invite Professor Saunders from Western Australia to come and be on the panel this afternoon is that, like Germany, though I think Christobel not quite to the same extent yet, there is at least a degree of national acceptance where you work in Australia, just as we've now heard so elegantly described by Frederik. To come back to the question, you have heard that what we have here is an intensely bureaucratic process. We have a system whereby it's very difficult to overcome what you might describe, for want of a better word, as medical inertia. You could call it conservatism, you could call it inertia. I think one thing is very important to remember, which is that breast cancer, this common diagnosis, represents, just the one diagnosis alone, represents approximately 30%, I think Margaret will bear this out because we worked so closely for so many years, around about 30% of a typical radiotherapy departmental workload. So you can imagine the knock-on effect for radiotherapy departments of losing this very large volume, or if you like, a proportion of this very large volume of work, is very, very substantial. So I guess I'm saying that there is a feeling that some of us have that there is a potential conflict of interest here. In other words, that radiotherapy departments recognise that what may be good overall for the country, and as you've heard from Bridget Both's analysis, and there's several others as well about the saving of money, this might be just a question of, fine, but not in my backyard. In other words, how do you save money? You save money by shaving the costs of radiotherapy. And in order to achieve that, it might then be necessary to think very hard about how many radiotherapy centres you need. Perhaps a more generous way of looking at it is to suggest, as the questioner has correctly done, that scarce resources, that is to say, radiotherapy, could be used with better effect for other things. So although this is speculation, as it were, the fact remains that it's been extremely difficult, and there's a disconnect between the beginning, the middle, and the end of the bureaucratic process. And here we have a situation where NICE has recommended the use of this technology to these centres which have the equipment and the expertise. And they're mostly, sadly, clustered around London. And also we know, absolutely, it's not difficult to get this in the private sector. And as I for one, as a clinical oncologist, feel very uncomfortable about a situation which is available to those who can pay, not available to those who can't pay. Why? Because it's obvious to the major insurers who deal with millions of pounds of fiscal burdens, Bupa, AXA PPP, that this is fantastic from their point of view. It costs them far less. So although NICE has recommended it, we have to persuade NHS England to pay for it. And
but Jeff, if you look at most radiotherapy departments, they're having the greatest difficulty keeping to the 62-day treatment date. I mean, you'd think they'd be absolutely delighted to have 30% of their radiotherapy patients taken away so that they could then get on and get their others treated in a meaningful way.
Provided they don't lose money. Yes, I agree. I think I've said quite enough.
Anyway, other questions? Thank you for that one, Katie. Yes, please. No, can you pass up the microphone? Thank you. Thank you.
I recently had breast cancer and a lumpectomy 2 months ago, and I decided not to have radiology. I knew nothing whatsoever about Target until I was checking online coming here at the itinerary and thought, Target, what's that? Now I know. And obviously I feel very disappointed, and I'm wondering if there's anything can be done at this late stage 2 months after.
So you had your lumpectomy,
yes,
but you just didn't have any radiotherapy after
Correct,
that?
yes. I decided not to do that and not to take the tablets.
That is something that probably someone would like to have a quiet word with you about afterwards, do you think? I don't know who we will identify.
Okay.
Person on my right.
Yes, yes.
Well, actually, Christobel has probably got the most experience with delayed radiation in this sort of setting, though 2 months is quite a long time.
So when we set the Target study up in Australia, I live in Western Australia, which is a huge state, and some ladies come from 2,500 kilometres to the only city in WA, Perth, to have radiotherapy or to have their treatment for cancer. And we also only had one machine in town, and there's a number of different hospitals. So we had the clever idea that we would take ladies from any hospital and from anywhere and give them they could have surgery at any hospital, and then we set aside a Friday afternoon operating list to do all the intraoperative radiotherapies as a second procedure. That seemed to make complete sense to us because it meant people could come from anywhere and all have it on one day. It was good for our working out our operating theatres, and we also thought that way we'd know that they had these very low risk cancers, which are the ones that we wanted to give the intraoperative radiotherapy to. And actually, I think Denmark did the same thing. Copenhagen was the only other centre that did the same thing. Unfortunately, we found in the trial that what I thought was a very clever way of doing it wasn't the ideal way. And we now know that actually if you give it at the same time as your initial surgery, it's probably better. Saying that, however, there's not a huge amount of difference. It did mean that there was ladies who had it as a second procedure had a slightly higher chance of breast cancer coming back than those who had it at the same time. And we've tried to think why, and Jay's thought a lot about this, and we think probably, to be honest, it's because we weren't actually delivering it to exactly the right spot. But it also might be a little bit about what Frederik was talking about with that biology of that wound fluid. So yes, you can have it as a delayed procedure. 2 months might be a bit late because it's hard to find. The body's very good at healing. So after an operation, immediately afterwards, there's a hole, if you like, where you can put the machine. But over a few months, that hole sort of closes up and it makes it harder to do it. So we've now come to the conclusion in Australia the government fund it to do it have it the same time as the initial surgery, but for some women it might be appropriate to give it as a later procedure.
If in the event the cancer returned, is it then possible to do this?
Yes, it would be possible. If it returns, you've not had any radiotherapy, so it would be possible to, depending on the type of cancer, it is likely, it's possible to remove the lump and give radiotherapy during that operation.
That sounds a thoughtful way of going about it. Well done. Thank you. Any other questions? Yes, please.
Can I just ask the panel, in view of the recent Montgomery ruling, where patients should be offered the treatment, even if it's not immediately available in their hospital, and the patients have the right to choose for themselves what treatment is best for their personal circumstance, how can a member of the panel offer something that isn't funded by the NHS, even when it's proven to be better? Because you're either breaking the law by not offering it, or offering something that you can't deliver.
Will this be covered in the discussion on the law? We're going to have a discussion afterwards. Yes.
Montgomery says that.
Okay.
I think it's more about consent. It's not obliging any doctor to offer any treatment. It's about how you consent the patient.
But part of the consent is to give, is to give the different treatment options available.
Yes, available, and also we're talking about public health, public resources, politics, just like caesarean. If I go and say I want a caesarean, the doctor goes, well, I actually, obviously the risks are here and here, but at the end of the day, if it's a policy decision of the trust, it's very, very hard to challenge it on a clinical negligence basis, because actually the doctor's not negligent, because the procedure or operation, or what we're looking at here, is not a negligent procedure. This is obviously the best option, and I think it's amazing. But it's resources, it's public money. It may be that patients have got to judicially review public body, and that's the way to go. And maybe there needs to be patient. There needs to be patient. That's what we're going to talk about, is the patient side of things, that they have to be more forceful when we get together and say, actually, as we with breast cancer, we want these options, and maybe that's the way forward, as Mike Farr was saying earlier on. But it's not really negligent not to,
Thank you, and we look forward to your talk.
Okay. Sorry.
Any more questions?
It was actually more of a proposal. In my experience, when you're really desperate, you go for the human rights aspect. And I would say here that there is some ground for it. I'm wondering whether some disaffected patient might get some crowdfunding and run something on that basis, that they are being deprived of the best treatment.
I think we mustn't get into your talk. It would be unfair to do that. Can we get Tony Howells as a question, please?
Christobel, a little more about how things have gone in Australia, and presumably it's gone faster because of the distances. Is that right?
No, it hasn't gone well.
Oh.
Really? No, and it hasn't gone well for a number of reasons. Probably the main reason is that although the government did agree to give what we call a Medicare item number, that is funding for intraoperative radiotherapy using this particular target device, at the same time as breast-conserving surgery for a delineated group of people, the funding it gave it was quite small. So it was considerably less money than a normal course of external beam radiotherapy. And Australia have gone the way of if you like, farming out most of our radiotherapy services to private providers, and the public services buy it off private providers. So consequently, for political and financial reasons, it hasn't gone that well. The other problem is that the machines have to be bought by individual hospitals, and it's a lot of money for an individual hospital, and it doesn't come under a funding arrangement that helps buy large radiotherapy machines. So it's all to do with subtle ways that government can change things in their funding models. And so, in fact, it has recently taken off using a different kind of machine, but I don't think that matters, but intraoperative radiotherapy in Victoria, because a large public hospital have bought a machine. I'm in the middle of trying to get a machine for one of our private hospitals, and interestingly, it's the private health insurers who have been one of them, just one, a local one, who put the block on it, because they say that normally they don't fund inpatient treatments and radiotherapy is an outpatient treatment. So it's all ridiculous politics.
Can we ask Professor Douek what should we do next? What's the next thing to do to try and get
Well, I
this
was hoping
accepted?
you wouldn't ask this, because both myself and Marcelle spent the last 5 years sitting on these various NICE panels. And it became quite apparent that the whole process lacked a certain degree of transparency at the outset of it. What I mean by that is that there is a process that runs, and experts are invited and experts are listened to, but the process starts with some unnamed individual or individuals within the Department of Health who are not known to anyone. They make the decision, rather than NICE, that certain topics need to be discussed, and then they provide the funding necessary for that discussion, which is quite a lot of funding, several hundreds of thousands of pounds. And so that creates an immediate conflict of interest in the whole process. But what should we do next? Well, I'm afraid the only way of dealing with it is by addressing these issues. And what we need is really a National Institute of Clinical Excellence, which is independent of the Department of Health, and that decisions made by this independent panel are binding, in that the Department of Health, should they wish to provide radiotherapy facilities, need to then provide the necessary funding. And they can't make that announcement unless they do make the funding available. Now, what is very disconcerting in the whole process, many things were, but one in particular, is that within closed doors, the committee did concede that intraoperative radiotherapy was cost effective and was thus cheaper to the taxpayer. But that important information didn't make it to the guidance. And so the real question, and I think maybe there's a legal angle, is based on the current setup of the National Institute for Clinical Excellence, or whatever they're called, are they legally bound to provide treatments that are found to be cost effective? Because as far as I'm concerned, that's what they're about. And the next question is, as a national health service, if there is a treatment which is effective but not cost effective, should the patient have the right to pay for the difference between the cost effective and the effective? Because I think that is what we need, full transparency in the system.
But it's most unreasonable, isn't it? I mean, call me old-fashioned, but to have something that is private patients can get that NHS patients can't get, I think is most unethical. It reminds me of the days when some horrible chemotherapy had just come out, and the private patients, because you knew everyone would be sick with the chemotherapy, the private patients could have these expensive new anti-sick drugs before they had the first course, whereas the national health patient had to vomit on the first one before they could get the antibiotics, the anti-sick tablets the next time. And that's the only time, I think, in my career I really felt enormously affronted, but I'm affronted by this now, as I'm sure you are. Any other questions, please?
One point there.
Oh, yes.
Is that it was available on NHS. We did the trial in the NHS, and until there was a widespread publicity of the results, it was happening in the NHS. Patients got it. And then suddenly somebody looked up, oh, we're not getting paid right for this. And suddenly, just when NICE approval was coming, we couldn't do it. It's so paradoxical.
And the other aspect, if I may, Margaret, is that we are breast surgeons, and we provide a whole range of surgical procedures to our patients in the name of oncoplastic breast surgery. In other words, preserving the breast and rearranging the breast tissue right, left, and center to give the patient a good cosmetic result. The ultimate aim has been and remains to prolong life, or to prolong quality of life, as Mike Baum mentioned. None of those other procedures are backed by level 1 evidence. There isn't a randomized controlled trial to back oncoplastic breast surgery. But when it comes to IORT, the trial is not praised for having got this far. In other words, 17 years or 18 years down the line, and 3,500 patients published in the Lancet. But it's criticized, and the critics are not going to be silenced by evidence, it seems. I don't know what will silence them.
Thank you. Another question, please. Sure. Oh, Katie, we have another one.
It's a very quick everyone from the group. My daughter is 37 years old and has just been diagnosed with early stage breast cancer. She's been told she has to have a lumpectomy next week. Can she have this treatment? She's 37.
And lives where?
Oh, doesn't say.
Well, the cutoff for the Target A trial was 45, and we chose that, probably wrongly, but we chose that because incidence of recurrence is less, about 45. But the Target B trial is in younger patients in whom we are trialing whether giving an intraoperative boost to the tumor bed in addition to whole breast is superior in cancer control. And that trial is running in the UK, and that she should be eligible with, but I don't believe it will be practically, I'm sorry to say, possible unless she is in very close to one of the few centres where we are running the trial. We're running it in 6 centres: Harlow, Swindon, Royal Free, Whittington, and Guy's Hospital, and Winchester. Yes, so these are the 6 centres where the Target B trial is running, and even there, it is difficult to accrue because of this problem that we are not even just allowed to deliver it. And it is paradoxical. We've recruited the largest number of patients in the trial, and then it was stopped.
And now the lady at the back, please. Thank you. Yes?
Yeah, no, I just wait for the microphone. But I can just ask you without the microphone. Hi, I just had a quick question about so what happens with Target if the surgeon doesn't get clear margins? Is there a procedure for that?
So patients they have an re-excision of margin as before, as would happen normally. And in the protocol, because patients who have positive margins are thought to be biologically slightly different and of higher recurrence rate, they are also, the protocol advises that they get whole breast radiation in addition.
Okay, thank you.
And have you mentioned nodes? What happens with the nodal status?
Well, if there are multiple lymph nodes involved, then also the protocol mentions they should have whole breast radiotherapy.
And that's a separate incision to take the nodes out? Is it a...
It's as usual, a sentinel node biopsy is done as a separate incision, and axillary clearance was done during the trial if they were not positive.
Thank you.
I don't suppose you want to sort of give us any more about why patients might be higher risk with if the margins aren't clear?
Those risks may not be as high as they used to be in the literature. In fact, during the Target A trial, we did not find that patients who had positive margins in the Target A who received intraoperative had any more chance of local recurrence than those who did.
But if I may add, Jay, one of the most interesting, for me anyway, results of the Target trial was a very, very low second operation rate, which I believe was 9%.
7 or 9%.
So when you have a situation where the surgeon, i.e. myself or Jay or whoever is doing the procedure, has to get it right first time, or else the patient, unfortunately, has to have a second operation and the radiotherapy that follows it, it puts us under a degree of scrutiny, which is good for the patient, because we need to avoid that re-excision more so than if we were not giving you intraoperative radiotherapy.
And interestingly, the margin positivity in the Target A trial was 7 to 9%, whether they were randomized to receive intraoperative or randomized to receive normal radiotherapy. Somehow, that was the worldwide rate. It's much better than what we've seen in literature.
And the UK statistic is well known, 20% reoperation rate. That's the standard reoperation rate in breast conserving surgery.
Other questions? Yes.
My question is around a potential way forward, which people are wanting to ask about. I've seen quite a lot of successful petitions on change.org, and if there's something specific that we ought to be asking, we could put together something which is quite powerful. We're now getting the audience there, we could get the ball rolling, and that can put pressure where it needs to go, because that petition can then be presented to NHS England or whoever it is we feel might have the most power to do something about it.
I'm sure I'm speaking completely out of turn because I'm not English anymore, but I've just come from NHS England headquarters meeting the head of quality of NHS England, Tim Briggs, who's an orthopaedic surgeon who's started a programme called the Getting It Right First Time programme. I also met Fiona McNeill this morning at the Marsden, who's the head of the breast surgery. And the idea, Tim started this programme, he's an orthopaedic surgeon, and he realised there was huge differences in quality of the outcomes in orthopaedic surgery in different hospitals. And so he was given a little bit of money from the NHS to try to find out what those differences were and improve them and save the NHS millions and millions and millions of pounds by making everybody come up to one standard and looking at some of those outcomes. This would seem an obvious thing to try to put into this programme and to take to the head of quality at NHS England, who's just bought me a cup of coffee because I hadn't seen him for 35 years since medical school, which was very nice, and say, you know, this is a great way of improving quality but also improving cost. And if that's what the NHS wants to do at the moment, which it clearly does, it would seem ideal.
The petition should probably say, please follow NICE recommendation. That is all, at least, and give patients choice.
Well, I think it is about spreading the word, which is why I think a petition could be quite a good way to go, because that is absolutely about spreading the word. And I'm happy to join forces with somebody else to put that together if it's seen as a good way to go.
That sounds excellent.
It
I'm
really
sure.
is. We really should. Apart from anything else, what I came up against when I was diagnosed was, I'm sure, again, it was back to people thoroughly believe what they say, but I kept coming up against, yes, but the gold standard is lumpectomy and external radiotherapy. And it was as if I was saying something that was almost a dirty word by it being outside of that. And I think what we might be wanting to present is maybe there's a new gold standard.
Yes. Over there, please, and then here.
Yes, that's the problem. Is always going to be a mixture of, you're always going to come across a breast surgeon who says whatever they said to Marcelle. You know, that's the real problem we've got, is that there's just not one message, even though this is all logical and of course sensible and right. There is a mixed message out there, and it's very difficult.
That's why I think
it is clarification.
Thank you.
I would just like to ask what Professor Baum said this morning, that we need to get out there and we need to be passionate about this. Do we think the NHS is culturally ready for a room full of non-academics, who I would generally class myself? I'm not an idiot, but I'm certainly not an academic. Is the NHS culturally ready for a group of people like this to approach it and say, come on guys, grab them by the scruff of the neck and say, come on guys, you've got to now start thinking slightly differently, and maybe, whilst scientifically thinking out of the box, think more empathetically out of the box. Is the NHS actually ready for us to demand something like this?
Is this the Whitehall March that he was talking about?
I think we've got to make them ready, haven't we? There's never going to be a time when they all turn around and say this is a brilliant idea. I don't know why they're so against it. I don't know what weird cultural limit they've set on themselves. But the fact is, Jeff has always said patient power is going to move this. And I think if there are enough of us shouting about it and enough of us informed, that's going to push it forward to a degree.
But I think there's if I look at the cancer, you go onto the charitable cancer websites. It was the first place I went to. I was banned. My husband banned me from Google when I was diagnosed. Because obviously you see the terrible videos and you read the terrible stories, and all of a sudden you're going to die. You go from having some sort of hope, and then sort of within a week you're dying. And I think for me there's not enough information even on those websites that give you some indication of what actually is out there and who you can talk to.
You're right, it isn't there. I've looked too. You're right.
Mike, Professor Baum wants to...
Apropos this discussion, I want to make two different but linked comments. This morning you heard a debate on the harms and benefits of screening, and the two of us concluded, we came together at the end, that risk assessment, risk management, triage would be the best way forward by screening those at an intermediate to high risk. I said, in addition to that, if we could get rid of the toxicity of the treatments, then we've got a dream team. And here we have treatment. Jay showed the figures for the screen-detected cancers, significant advantage, beyond doubt, in the screen-detected subgroup of, more than 67%, how well they did with intraoperative radiotherapy. So if we had selective screening and intraoperative radiotherapy for the screen-detected cancers, then it's a dream team. And there should be nothing impeding us to do that, but there is. And the second point I want to make, I was asked by the Daily Mail correspondent, who may be publishing something tomorrow on this, could I explain what all the delays were about? And I said, to be honest, I'm mystified, but I have little doubt that there are undeclared conflicts of interest. And I'm repeating that. I'm an emeritus, I've got nothing to lose. There has to be, I would like an investigative journalist to look at this, because throughout the NICE process, I was just in the audience, I wasn't even involved in it actively. I had the impression that there was something other than evidence being discussed. And I have little doubt that there is some undeclared conflicts of interest here.
Gosh, that's frightening.
If I may second that, as the surgical expert and Marcelle was the patient expert sitting on the committee, I had to sign a confidentiality agreement, and yet I was only ever allowed to be present and to be party to discussions that had a public arena. And I was invited to leave the room in the same way as Mike Bauman, as the patients of the audience. Now, in my book, that is not transparency, and I still don't know why I was asked to sign an agreement which is effectively a gagging order.
Yeah, and me too. And they wouldn't let anybody stay in.
We weren't allowed to come.
We were treated like the audience, although we were part of the panel. What is that about?
We have...
So, can I ask each of you, is NICE fit for purpose?
Is what? I beg your pardon?
Is NICE fit for purpose?
Oh, good question.
I think it is fit for purpose, but it does need tweaking. And bearing in mind it has been set up in, I think, 1999, quite some time ago. And I think the reason why we are sharing these concerns is because it is important to improve NICE. It's one of the assets we have.
So we don't want a baby in bathwater scene.
We want a better NICE.
Yes.
But the difficulty is this wretched disconnect between what NICE says. What NICE said was, yes, we wish to see this used in the centres that already have the equipment and the expertise. That's all very well, but unless NHS England are prepared to at least foot the bill for that, what we need to know, in answer to your question, is NICE fit for purpose, is whether it is armed with sufficiently sharp teeth that its recommendations should be, and you might even say must be, taken forward. And as a corollary there, we heard this morning from another speaker in another context about the difficulties of getting through things even up to the first hurdle, first base. Well, we're well beyond that. And part of the answer that was given this morning, which was absolutely correct, is that the standards of NICE, of the exhaustive nature of the process, are very, very high. So what we can say, I think, on our own behalf, is that we've been put through the mill. We've really been through this extraordinary 5-year process, and they've still made a recommendation. It may be a limited one, but it's a recommendation. So how then, after that exhaustive process, which is meant to be the gold standard, are we still stuck with this difficulty vis-a-vis NHS England? That's where we need to act.
Can I alter the slant ever so slightly? I mean, having spent a lifetime trying to treat patients with breast cancer and with very clever surgeons, we've worried a lot about the cosmetic result. Now, we actually haven't seen, I think, a photograph of a post-operative patient. I just have to assume that the result is excellent, because there are two things altered with intraoperative radiotherapy. One is giving the radiotherapy to the area of the primary site, and the other is not irradiating the rest of the breast. And when, I think it was in the 60s, in Manchester, they decided that they would just irradiate the area where the lump was. But unfortunately, so they said, yes, if we just give 10 doses of radiotherapy to the area where the lump was, surely we don't need to give that whole big radiotherapy. And they did a very good trial, but unfortunately, in trying to give the treatment in 10 doses, they miscalculated the dose of treatment that people should have. And so, unfortunately, what actually downed it was not the result that the patient's disease was recurring, etc., but that the cosmetic result they got was so horrid because they managed not quite tweak the dose of radiotherapy to be given in 10 sessions well. Can you tell us about your radiotherapy, your cosmetic result?
The cosmetic outcome in the randomized trial have been looked at, and they are better, if not at least the same, even when it is given as a second procedure. And this has been looked at. Breast-related quality of life is better, and as Marcelle said, as an anecdote.
Yeah, we also ran a quality of life study in our patients, and it was clear that breast and arm symptoms are improved when you receive intraoperative treatment only compared to the standard whole breast. So there was a significant advantage for quality of life, and again, that's what counts for the patients.
What sort of arm symptoms?
Pain movement disorder.
I mean, do we treat the arm these days with radiotherapy, even external beam radiotherapy?
With the tensions, you at least have parts of the pectoralis muscle always in the treatment, and that leads to movement problems.
I would go further than the other speakers who replied to this question. I think the result cosmetically, leave aside quality of life, cosmetically is unequivocally better. It is better in several respects. The texture of the breast is better. The way in which the breast will continue on its slightly downward path in exactly the same way as the other side. This is quite a serious point. As time goes by, of course the normal breast begins to travel south. And the irradiated breast, and I'm talking about traditional whole breast radiotherapy, does not. So the degree of asymmetry gets larger and larger and larger, but not with target radiotherapy. Why? Because you're only treating essentially around the scar. That's reason number one. Reason number two, and this is not trivial for very many women, every patient who gets whole breast radiotherapy needs a tattoo. They need to have a tattoo for laser guidance of the radiation field placement. There's one round the side that nobody can see. There's one right in the middle of the cleavage, just where my third button is here, which everybody can see. It's not very big, but it's lifelong, and it begins to bleed out into the skin, and patients don't like it. With target, you don't need that. It's an unnecessary step.
We used to do it with henna.
Apropos of that, can you hear me?
Yes.
Yeah, apropos of that, I want to pay tribute to Mo Keshgar.
Thank you.
Mo Keshgar died tragically last year. Mo was one of the team, and he was responsible for educating other users. He did a meticulous study of cosmetic outcome using a computer-generated model photographing the breast, and so you had a automatic evaluation, not subjective but objective, and there was no doubt the quality of outcome, the cosmetic outcome, was better in IORT.
Yes, I'm glad you paid tribute to the late Professor Keshgar, who was very enthusiastic about this.
Hello, I've got the mic, so could I go next, please? Again, I speak as someone who has had intraoperative radiotherapy, and I just want to confirm a couple of points, but also then to make a point about how we promote this approach to treatment. I can confirm that the after effects of IORT were magnificent. I could have actually returned to work 2 weeks after my surgery. I mean, Dr. Mazerat in Italy said he would have me back at work after 2 weeks, but I'd already been given a month off by my GP in Birmingham. I was just so relieved to find it, but I just wanted, this is another point I wanted to make. It took me 2.5 months to find out where I could have this treatment. And that was after reading about it on a BBC News website on my phone in the middle of the night, a point at which I'd had my surgery in Birmingham cancelled because I suffer from white coat syndrome, which makes my blood pressure go up to extremely high levels. And I realised then that I couldn't possibly stand 4 weeks of external beam radiotherapy, quite apart from what I read, and I did an extensive amount of research on the whole topic area of the effects of external beam radiotherapy. And I found out about Professor Vaidya in a very devious way, actually, after 2.5 months research. It was via Nine Wells Hospital, actually. And again, I confirm, yes, I got a phone call early in the morning, and I was down in London the next day speaking to Professor Vaidya, and it was arranged that I would go to Italy. And yes, I had to pay for it. But the other point I wanted to make, actually, is about how we promote information about this treatment. And I really would like to know, actually, how many people in the room knew about intraoperative radiotherapy before this conference. So could I have a show of hands? How did you know? Did you know about IORT? Oh, it's quite a fair number. That's
I think that's.
Oh yes,
why
I was going to say how many people have had IORT. You have. Yes, so that's really good actually. So I am amongst some friends, but I think what we've heard actually in the last few presentations is what's been said about it in the scientific community. And it's very much quantitative analysis. I mean, I'm a social scientist and I also favour qualitative methods. And part of that is talking about one's experience. And I think there's a case for people here, we who know about it, going and giving talks. I mean, I would actually love to go into Birmingham's Women's Hospital and give a talk to the people who are there being tested for having screening for breast cancer to promote alternative approach to treatment. I would say actually I've been doing that sort of thing on behalf of the Sepsis Trust because my husband died suddenly and unexpectedly last year due to sepsis. So I've become a volunteer for the Sepsis Trust and I'm going around giving talks about sepsis.
Well, I'm sure that's possible. I mean,
something like that.
The equation the person we haven't mentioned in all the discussion today is the breast care nurse. And I think that if you have a breast care nurse, then they may be able to arrange that you talk to maybe a patient group, which many hospitals have, and that would be a very constructive thing to do, I would have thought.
And Margaret, if I may just respond, in terms of the practicalities of IORT, I think you're making an important and valid point. In terms of it becoming available or patients finding out about it, there are quite a lot of cooks involved in getting it to work, and we've mentioned funding by the NHS, which hasn't made it possible, essentially. It's not approved yet on a funding basis. But then the radiotherapist has to prescribe it. And the radiotherapist won't prescribe it unless, of course, they believe in it and unless it's funded. And then the surgeon can't offer it to a patient without that prescription. So effectively, I can't offer it and Jay can't offer it without that prescription from an oncologist. So you need the prescription, you need the funding, you need the machine, and then you need to start the process of deciding, in the same way as Professor Wenz did in Germany, of putting together some guidelines and agreeing which patients should be offered the treatment. We can't even get to that stage before we complete this stage, which is endless. We've been through it for 5 years. I didn't know that I was putting myself in for 5 years of nice meetings. I wouldn't have, you know, for the bus fare. I wouldn't have done it, quite frankly. Particularly if I felt that at the end of the process it wasn't going to be a binary, if I knew that it wasn't going to be a binary outcome, approval or non-approval, I wouldn't have got involved.
Can I just ask if there's any oncologists who don't take it on board as the science, the results, the statistics? Are there any credible oncologists or doctors who are not on board with this? And then that makes it quite difficult, I think, if you have got a body of doctors who are just saying, actually...
A body of oncologists, so the Royal College of Radiologists, and I believe that there was considerable difficulty in
hostility.
There's a question on our group that says, I don't mean to be a cynic, but is this possibly being blocked because radiologists will be out of a job?
Well, we've been asked that question a number of times, even in public fora. And I think the answer is no, of course you won't be out of a job, but you might be required to do different things. The way I see it, very many advances throughout the whole history of medicine have been essentially the recognition that what was previously regarded as an important standard treatment is unnecessary when it's replaced by something better. Look at how, when I was a house officer in 1971, we had loads of patients coming in for partial gastrectomies for their stomach ulcers. Now, it's never done because we've got decent medication, very straightforward medication, with all sorts of very simple and effective drugs. The same is true in, for example, the history of tuberculosis, the world's biggest killer at one point. Massive operations, thoracoplasties. Nobody does that now. Nobody's done it for 40 years. Why? Because medication has come along. In the same way, and of course, the body of opinion always is very upset and squeals about the change which is required of them. This is, I think, very much part of the same story. Mastectomy was probably another very good example.
Thank you. Now, just to close this session, last comment from Professor Baum.
I'd rather listen for Jeremy.
Oh, I'm so sorry. Yes, good.
Thanks, Mike. No, I'm a radiation oncologist too, and I think along the same lines like Jeff. You don't want to do things that are unnecessary, even if you get paid for. And therefore, I mean, this frees up time at the linear accelerator to do the thing that really matters, to treat young patients with Hodgkin disease and other things where you are curative and where you make a difference. But let me add one final thought. I mean, this was the thing that Dr. Blooming brought to my mind when he talked about the castration of women and men. What about the Da Vinci robot here in the UK? I mean, there's no randomized study showing that it's better. There's no advantage. It's more expensive and it's offered to men in the UK. We are talking about gender equivalence. How do you call it? Gender equivalence?
I'm sorry, what were you talking about?
The radical prostatectomy with the Da Vinci robot. It's more expensive. There's no piece of data showing that it's advantageous, and it's offered. And
This
it's paid
is
for.
remote surgery, is that right?
Yes.
Robotic assisted
And
surgery.
accepted with no problems. Yes, of course we'll have it.
So why is that accepted?
Good point. Because it's for...
And on that point, thank you very much indeed. You've been the most informed audience. I was amazed that, well, of course you all knew about it because you wouldn't have otherwise come. We have a very, very, very important and you could not get a better informed panel on this subject. So we've been privileged to get, and they won't be quiet. Jay, what do you want to say?
If anybody who's interested in having this group communicate after this meeting finishes, please give your email address and we'll circulate a paper.
Good idea.
And if we do that, we can create a Google group and we can talk to each other, continue to do so in the days to come and probably make things happen. Is that okay?
There's an offer.
Thank you.